Welcome to Pediatric Case Review. Today's lecture is a comprehensive case-based review of juvenile dermatomyositis, designed for general pediatric physicians. Our guiding principle for this condition is recognize early, treat promptly, and prevent damage. We will work through 14 interactive clinical cases covering clinical presentation, pathophysiology, myositis-specific antibodies, diagnostic criteria, investigations, treatment algorithms, and complications. Let us begin. Question 1. Clinical presentation. A 7-year-old girl presents with a 6-week history of progressive proximal muscle weakness, difficulty climbing stairs, and a purplish rash around her eyelids. Her parents note she cannot raise her arms above her head. Examination reveals tender proximal muscles. Which of the following rashes is most characteristic of juvenile dermatomyositis? Option A. Malar butterfly rash sparing the nasolabial folds. Option B. Heliotrope rash with periorbital violaceous discoloration. Option C. Erythema marginatum with central clearing. Option D. Salmon-colored evanescent truncal rash. The correct answer is Option B. Heliotrope rash with periorbital violaceous discoloration. The heliotrope rash is pathognomonic for juvenile dermatomyositis. It is a violaceous, purple lilac discoloration of the periorbital skin and upper eyelids, often accompanied by eyelid edema. It frequently occurs alongside Gottron papules over the knuckles. Memorizing the rash-to-condition pairing is essential for board examinations. Heliotrope rash means juvenile dermatomyositis. Malar butterfly rash with nasolabial involvement means systemic lupus erythematosus. Salmon pink evanescent rash means systemic juvenile idiopathic arthritis. And erythema marginatum means acute rheumatic fever. Question 2. Clinical presentation. An 8-year-old boy with known juvenile dermatomyositis is brought for follow-up. On examination, you notice raised, scaly, violaceous papules over the dorsal surface of his metacarpophalangeal and proximal interphalangeal joints. Which term best describes this finding? Option A. Mechanic hands. Option B. Raynaud phenomenon. Option C. Gottron papules. Option D. Calcinosis cutis. The correct answer is Option C. Gottron papules. Gottron papules are pathognomonic of juvenile dermatomyositis. They are raised, scaly, violaceous papules located over extensor surfaces of joints, particularly the knuckles, elbows, knees, and ankles. It is important to distinguish them from Gottron sign, which is a flat macular erythema over the same areas rather than raised papules. Mechanic hands describes cracked, fissured skin on the lateral fingers, a finding more typical of adult dermatomyositis and overlap syndromes. Calcinosis cutis refers to calcium deposits under the skin and is a later complication, not an acute presenting sign. Question 3. Pathophysiology. A pediatric rheumatologist is explaining juvenile dermatomyositis pathophysiology to medical students. She describes an autoimmune process where type 1 interferons are upregulated, leading to capillary injury in muscle and skin. Which of the following best describes the primary immunological mechanism in juvenile dermatomyositis? Option A. Mast cell activation triggering immunoglobulin E-mediated inflammation. Option B. T-cell-mediated cytotoxic destruction of muscle fibers. Option C. Neutrophil degranulation causing sarcomere disruption. Option D. Complement-mediated microangiopathy with capillary loss. The correct answer is Option D. Complement-mediated microangiopathy with capillary loss. Juvenile dermatomyositis is fundamentally a vasculopathy more than a primary myopathy. The pathophysiological sequence begins with upregulation of type 1 interferons, which activate the complement cascade. Complement activation leads to deposition of the C5b 9-membrane attack complex on capillary endothelium. This causes capillary endothelial injury and progressive capillary dropout, resulting in parafascicular muscle atrophy and skin vasculopathy. On muscle biopsy, the hallmark findings are parafascicular atrophy, paravascular inflammation with CD4 positive T cells, B cells, and plasmacytoid dendritic cells, and capillary loss. Unlike adult dermatomyositis, malignancy risk in juvenile dermatomyositis is very low. Question 4. Pathophysiology. Regarding the role of myositis-specific antibodies in juvenile dermatomyositis, which of the following is correct? Option A. Anti-MDA5 antibody is associated with rapidly progressive interstitial lung disease in juvenile dermatomyositis. Option B. Anti-Jo. One is the most common myositis-specific antibody in children with juvenile dermatomyositis. Option C. Myositis-specific antibodies are present in the majority of adult dermatomyositis, but absent in juvenile dermatomyositis. Option D. Anti-Me2 antibody is associated with severe calcinosis and poor prognosis. The correct answer is option A. Anti-MDA5 antibody is associated with rapidly progressive interstitial lung disease in juvenile dermatomyositis. Myositis-specific antibodies are present in juvenile dermatomyositis and directly guide prognosis and treatment intensity. Anti-MDA5 stands for melanoma differentiation-associated gene 5 and is strongly linked to rapidly progressive interstitial lung disease, skin ulcers, and amyopathic or hypomyopathic juvenile dermatomyositis. Anti-TIF1 gamma is associated with severe skin disease and photosensitivity. Anti-NXP2 is linked to calcinosis and severe muscle disease. Anti-Me2 is associated with classic skin rash and a favorable steroid response. Anti-Jo1 is rare in children and is more characteristic of adult antisynthetase syndrome. Question 5. Examination findings. A 9-year-old girl with juvenile dermatomyositis is assessed for muscle strength. On examination, she struggles to rise from a seated position without using her hands, cannot climb stairs without holding the railing, and her Gower sign is positive. Which muscle groups are primarily affected in juvenile dermatomyositis? Option A. Extraocular muscles and facial muscles. Option B. Distal limb muscles and intrinsic hand muscles. Option C. Proximal limb girdle muscles and neck flexors. Option D. Respiratory intercostal muscles primarily. The correct answer is option C. Proximal limb girdle muscles and neck flexors. Juvenile dermatomyositis characteristically affects the proximal muscle groups in a symmetric pattern. Shoulder girdle weakness presents as inability to raise the arms above the head. Pelvic girdle weakness produces a positive Gower sign and a waddling gait. Neck flexor weakness causes head lag, meaning the child cannot lift the head from the pillow. Distal muscles are typically spared in early disease. Pharyngeal weakness causing dysphagia is a danger sign requiring urgent intervention. Muscle strength is formally assessed using the Childhood Myositis Assessment Scale, which evaluates neck, arm, trunk, leg, functional, and gait domains. Question 6. Examination findings. During examination of a 10-year-old with juvenile dermatomyositis, you note periungual erythema and dilated nail fold capillaries on naked eye inspection. What is the clinical significance of nail fold capillaroscopy findings in juvenile dermatomyositis? Option A. Indicates concurrent systemic lupus erythematosus. Option B. Is a specific marker for calcinosis development. Option C. Suggests imminent malignant transformation. Option D. Reflects underlying vasculopathy and correlates with disease activity. The correct answer is option D. Reflects underlying vasculopathy and correlates with disease activity. Nail fold capillaroscopy is a non-invasive and clinically valuable tool for assessing disease activity in juvenile dermatomyositis. In active disease, capillaroscopy reveals dilated capillary loops, hemorrhages, and avascular areas reflecting the underlying microangiopathy. Periungual erythema is visible to the naked eye without magnification. As disease activity improves with treatment, capillary architecture normalizes, making this a useful monitoring tool alongside muscle enzymes and magnetic resonance imaging. Similar nail fold changes are also seen in scleroderma and overlap syndromes. The clinical workflow is assess disease activity, examine nail fold findings, monitor response, and adjust treatment accordingly. Question 7. Investigations. A 6-year-old with proximal weakness, heliotrope rash, and Gottron papules is referred for workup. Laboratory results show creatine kinase of 2,400 units per liter, elevated lactate dehydrogenase, elevated aldolase, and mildly elevated liver transaminases. Magnetic resonance imaging of the thighs shows diffuse signal abnormality. Which investigation is considered the gold standard to confirm muscle inflammation in juvenile dermatomyositis? Option A. Muscle biopsy with histopathology. Option B. Serum creatine kinase level. Option C. Magnetic resonance imaging of affected muscles. Option D. Electromyography. The correct answer is option A. Muscle biopsy with histopathology. Muscle biopsy remains the gold standard for confirming the diagnosis of juvenile dermatomyositis and identifying the specific pathological pattern. Hallmark histological findings include parafascicular atrophy, paravascular inflammation, capillary loss, membrane attack complex deposition on capillaries, and fibronecrosis. Creatine kinase is a useful screening biomarker but has variable sensitivity and may even be normal in juvenile dermatomyositis. Magnetic resonance imaging using short tau inversion recovery sequences has high sensitivity and guides optimal biopsy site selection to avoid false negative results. Electromyography shows a myopathic pattern but is less specific and more invasive for children. Question 8. Investigations and diagnostic criteria. You suspect juvenile dermatomyositis in a 7-year-old. The 2017 European League Against Rheumatism and American College of Rheumatology classification criteria for idiopathic inflammatory myopathies use a probability-based scoring system. Which of the following is included in the core clinical domains of these classification criteria? Option A, elevated serum complement C3 and C4. Option B, serum ferritin level above 500 nanograms per milliliter. Option C, symmetric proximal muscle weakness. Option D, positive anti-double-stranded DNA antibody. The correct answer is option C, symmetric proximal muscle weakness. The 2017 European League Against Rheumatism and American College of Rheumatology classification criteria use a probability-based point scoring system across several clinical domains. These domains include skin findings such as heliotrope rash, Gottron papules, and Gottron sign, proximal muscle weakness in upper and lower extremities, elevated muscle enzymes including creatine kinase, lactate dehydrogenase, aldolase, and liver transaminases, dysphonia and dysphagia, biopsy findings of perivesicular atrophy, and magnetic resonance imaging edema on short tau inversion recovery sequences. A score of 7.5 or above without biopsy, or 8.7 or above with biopsy, classifies definite juvenile dermatomyositis. Complement levels and anti-double-stranded DNA are lupus markers, not juvenile dermatomyositis criteria. Question 9. Investigations. A newly diagnosed 8-year-old with juvenile dermatomyositis is undergoing baseline workup. Her rheumatologist orders pulmonary function tests and a high-resolution computed tomography of the chest. Which myositis-specific antibody is most associated with interstitial lung disease requiring urgent respiratory surveillance? Option A, anti-TIF1 gamma. Option B, anti-MDA5. Option C, anti-Me2. Option D, anti-NXP2. The correct answer is option B, anti-MDA5. Anti-MDA5 antibody, directed against melanoma differentiation-associated gene 5, is the myositis-specific antibody most strongly associated with rapidly progressive interstitial lung disease in juvenile dermatomyositis. The interstitial lung disease in anti-MDA5 positive patients can be life-threatening and requires aggressive immunosuppression beyond standard first-line therapy. These patients often present with skin ulcers, palmar papules, and amyopathic or hypomyopathic disease where muscle weakness is minimal or absent despite severe systemic involvement. Ferritin is often markedly elevated and serves as a poor prognostic marker. Monitoring requires serial pulmonary function tests, 6-minute walk testing, high-resolution computed tomography of the chest, and oxygen saturation monitoring. Anti-TIF1 gamma warrants cancer screening even in children. Question 10. Treatment. A 7-year-old girl is newly diagnosed with juvenile dermatomyositis. She has moderate proximal weakness, heliotrope rash, Gottron papules, and elevated muscle enzymes. She has no internal organ involvement. What is the first-line treatment for juvenile dermatomyositis? Option A, rituximab infusion. Option B, hydroxychloroquine monotherapy. Option C, intravenous cyclophosphamide. Option D, high-dose systemic corticosteroids plus methotrexate. The correct answer is option D, high-dose systemic corticosteroids plus methotrexate. The standard first-line treatment for juvenile dermatomyositis is the combination of systemic corticosteroids and methotrexate initiated simultaneously at diagnosis. Corticosteroids are given as oral prednisone at 2 mg per kilogram per day or as intravenous methylprednisolone pulse therapy for severe disease. Methotrexate is used at 15 mg per square meter weekly with subcutaneous administration preferred. If there is inadequate response after 3 months, intravenous immunoglobulin, cyclosporin, or azathioprine can be added. Rituximab, abatacept, and Janus kinase inhibitors are reserved for refractory disease. Hydroxychloroquine is used only as an adjunct for skin disease. Sun protection and vitamin D and calcium supplementation with steroids are mandatory. Question 11. Treatment. An 11-year-old with juvenile dermatomyositis has been on prednisone and methotrexate for 4 months with only partial improvement. Her muscle enzymes remain elevated and she still has proximal weakness. Her rheumatologist considers adding intravenous immunoglobulin. What is the most appropriate indication for intravenous immunoglobulin in juvenile dermatomyositis? Option A, as a steroid-sparing agent in refractory or severe disease. Option B, as routine first-line monotherapy. Option C, to treat calcinosis cutis. Option D, to prevent interstitial lung disease progression. The correct answer is option A, as a steroid-sparing agent in refractory or severe disease. Intravenous immunoglobulin is indicated in juvenile dermatomyositis when the response to standard corticosteroids and methotrexate is inadequate after 3 months, or in severe disease at presentation. The standard dose is 1 to 2 grams per kilogram per course given monthly. Dysphagia is a specific urgent indication for intravenous immunoglobulin or intravenous methylprednisolone because pharyngeal muscle weakness carries risk of aspiration. Calcinosis has no proven effective treatment. Diltiazem and bisphosphonates have been tried. Physical therapy throughout the disease course is essential to prevent contractures. Treatment response targets at 3 to 6 months include normalization of muscle enzymes, improvement in muscle strength by 20% or more, and reduction in magnetic resonance imaging muscle edema. Question 12. Complications. A 12-year-old with a 3-year history of poorly controlled juvenile dermatomyositis presents with firm, rock-hard nodules under the skin over her elbows and knees. Some lesions are discharging white chalky material. What is this complication and which antibody is most associated with it? Option A, tophi deposits associated with hyperuricemia. Option B, subcutaneous nodules of juvenile idiopathic arthritis associated with rheumatoid factor-positive disease. Option C, calcinosis cutis associated with anti-NXP2 antibody. Option D, subcutaneous fat necrosis associated with anti-MDA5 antibody. The correct answer is option C, calcinosis cutis associated with anti-NXP2 antibody. Calcinosis cutis is a debilitating complication of juvenile dermatomyositis, occurring in 30 to 70% of cases, which is significantly more common than in adult dermatomyositis. It represents calcium hydroxyapatite deposits in the skin, muscle, and fascia. The anti-NXP2 antibody is the myositis-specific antibody most strongly associated with severe calcinosis and severe muscle disease. Risk factors include delayed diagnosis and poor disease control. Complications of calcinosis include ulceration, secondary infection, contractures, and nerve compression. There is no proven effective treatment for established calcinosis. The most important clinical message is that early aggressive disease control is the best prevention strategy. Question 13. Complications and associations. A 9-year-old with juvenile dermatomyositis develops acute onset abdominal pain, bloody stools, and coffee ground vomiting. Urgent endoscopy shows multiple mucosal ulcerations in the bowel. Which of the following best explains this complication in juvenile dermatomyositis? Option A, corticosteroid-induced peptic ulcer disease. Option B, methotrexate-induced enteropathy. Option C, concurrent Crohn disease as autoimmune overlap. Option D, gastrointestinal vasculopathy due to juvenile dermatomyositis-related bowel wall ischemia. The correct answer is option D, gastrointestinal vasculopathy due to juvenile dermatomyositis-related bowel wall ischemia. The same complement-mediated microangiopathy that destroys muscle capillaries can affect small vessels in the bowel wall, causing mucosal ischemia and ulceration. Gastrointestinal vasculopathy is uncommon but represents a serious and potentially life-threatening complication of juvenile dermatomyositis that may require emergency surgical bowel resection if perforation occurs. Other recognized complications include interstitial lung disease in approximately 5 to 10%, higher in anti-MDA5 positive patients, lipodystrophy in 10 to 20%, joint contractures, which are common, and cardiac involvement including arrhythmia and myocarditis in less than 5%. Gastrointestinal vasculopathy must be recognized as a medical emergency distinct from medication side effects. Question 14. Complications and long-term outcome. A 14-year-old girl with juvenile dermatomyositis diagnosed at age 9 now has buffalo hump, central obesity, acanthosis nigricans, and elevated fasting triglycerides. She never had diabetes before. Which juvenile dermatomyositis-associated metabolic complication does this presentation suggest? Option A, lipodystrophy-associated metabolic syndrome as a juvenile dermatomyositis complication. Option B, Cushing syndrome from long-term corticosteroids only. Option C, hypothyroidism causing metabolic slowing. Option D, type 1 diabetes mellitus triggered by autoimmunity. The correct answer is option A, lipodystrophy-associated metabolic syndrome as a juvenile dermatomyositis complication. Juvenile dermatomyositis-associated lipodystrophy occurs in 10 to 20% of patients and represents abnormal fat distribution due to active disease rather than medications alone. It can be localized or generalized and leads to a metabolic syndrome characterized by insulin resistance, hypertriglyceridemia, fatty liver, and acanthosis nigricans. This is distinct from steroid-induced Cushing syndrome, although both conditions can coexist in the same patient. Management includes metformin for insulin resistance, dietary modification, and lipid management. Annual monitoring of fasting glucose, lipid profile, and liver enzymes is recommended. The pathway of active disease leading to lipodystrophy leading to metabolic syndrome carries significant long-term cardiovascular risk. That brings us to the end of today's lecture on juvenile dermatomyositis. The key takeaways are: the pathognomonic rashes are heliotrope and Gottron papules. Weakness is proximal and symmetric with neck flexor involvement. Muscle biopsy is the gold standard, and magnetic resonance imaging guides the biopsy site. Myositis-specific antibodies guide prognosis, with anti-MDA5 predicting interstitial lung disease risk and anti-NXP2 predicting calcinosis. First-line treatment is steroids combined with methotrexate and intravenous immunoglobulin for refractory cases, and early aggressive diagnosis prevents the devastating complications of calcinosis, contractures, and vasculopathy. If you found this lecture helpful, please follow Pediatric Case Review for more case-based sessions. We also invite you to join our Patreon community, Pediatric Case Review, where all videos are organized by system, all presentations are available as downloadable photo slides, and case-based question banks reinforce your learning. Comment below, and we will message you with all the details.